to be with you today. I'm Professor Sonia Nouri, Professor of Neonatology at Neonatology Department of Farhat Hashed Hospital, Sousse, Tunisia, and Faculty of Medicine of Sousse. I want to thank the Tunisian Neonatal Medical Care Association for inviting me to the moderation of its third webinar, focusing on necrotizing enterocolitis in newborns, a life-threatening and challenging condition for both pediatrician or neonatologists and pediatric surgeons. I'm very honored to have with us today our two distinguished guests from Egypt, Professor Adel Riyal as moderator and Professor Mustafa Abdelhadi as speaker. Welcome among us, professors. We'll also be present with us Professor Amina Qsia and Manal Bellallah from Tunisia. This webinar consists of three parts, two conferences. First one entitled Essentials in Necrotizing Enterocolitis, the neonatologist point of view, which will be presented by Professor Mustafa Abdelhadi. Then Professor Amina Qsia will present the second conference entitled Surgical Management of NEC. And finally, Dr. Manal Bellallah will present a clinical case, NEC in a premature infant, a challenging situation. I kindly invite the participants to mute their microphones. Please, for the participants, write your questions in the Q&R sections, and we will discuss them at the end of the session. Until now, I think we have 700 registered. We have about 150 participants who are with us now. Before starting, allow me to have a thought to Professor Najla Salem, Professor of Neonatology, who we just lost 2 weeks ago after a long and courageous battle with the disease. I personally had the chance to work with her for about 10 years. So let's see the video together. الله يرحمها ويصبر عائلتها وأحبابها. Now back to our scientific program. As I said, we have with us for the moderation Professor Adrian. He has a very long CV. I just try to present Professor Adel. He is a professor of pediatrics and neonatology at Banha University and Wadi Nil Hospital. He was the head of pediatrics and neonatology department, head of pediatric liver transplant unit, and head of infection control unit at Wadi Nil Hospital. Founder and former board member of the Egyptian Society for Neonatal and Preterm Care, the first neonatology society in Egypt, member of the advisory committee of the Egyptian neonatal guidelines. His main area of interest is CPD in neonatology, but also asthma, vaccines, nutrition, infections, and antibiotics. He is the president of NICAP, Mediterranean International Conference of Applied Pediatrics. He has been practicing neonatology for about 40 years, establishing and designing many NICUs, training their neonatologists and nursing staff. You are welcome again, Professor, and I invite you to introduce the lecture of Professor Mustafa Abdelhamid.
Thank you very much. Thank you very much. Really, it's a great pleasure and honor being with you, our dear brothers and sisters from Tunis. And really, I was honored by being invited to participate in such a wonderful meeting in the memory of Professor Najla Salim. May God bless her soul. Honestly, I'm gonna present my, what should I say, my dearest elder son, Mustafa Abdelazim. He is, I don't know what to say. I used to go, honestly, to the university to meet him, just to have the word round together, because he was eager to learn, and he is one of the eminent neonatologists now in Egypt, and he used to be a neonatologist in Saudi Arabia, and he's a professor of pediatrics and neonatology and the head of neonatal unit in Banha University in Egypt. I really enjoy working with him. I really feel honored to participate with him in such a wonderful symposium or meeting. Today he's going to talk about the one of the most alarming and most destructive disease in neonatology, which is the necrotizing enterocolitis. If you allow me to share my screen, I'm going to say a few words about the disease. Actually, necrotizing enterocolitis is a disease seen primarily in preterm infants. In some ways, necrotizing enterocolitis is a byproduct of the success experienced in neonatology, wherein babies of low gestational age who would not have survived 30 or 40 years ago are now surviving. That's why we started to see such a destructive disease. NEC has emerged as one of the most destructive diseases occurring in neonatal intensive care. In addition to extremely high morbidity and mortality and high costs, NEC or NEC carries long-term disabling complications. When examining the literature, one might consider NEC to be a single homogeneous entity, but actually it is becoming clear that NEC is several different diseases or endotypes. Progress in our understanding of the pathophysiology, prevention, and treatment of necrotizing enterocolitis has been hampered for many reasons. Included among these is the fact that what we are calling NEC is likely to represent different disease processes, which need to be delineated before evaluating individual pathogenic mechanisms and attempting to develop predictive and diagnostic biomarkers. Treatment is also likely to be hampered because not all of the different entities called an EC will respond to the same regimen. It's my great pleasure and honor to introduce Professor Mustafa Abdelazim to talk about the necrotizing enterocolitis from the pediatric neonatal point of view. Professor Mustafa, the floor is open for your presentation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Adel, for very, very kind words. As usual, you're supporting me everywhere, every now and every time. You are my mentor. It's my great pleasure to share in the first cooperation between the Tunisian Neonatal Association and the Egyptian societies. And I would like to thank Dr. Amin and Dr. Sonia for the kind invitation. I hope to be, inshallah, a good cooperation in the next sessions, inshallah. I will go rapidly in the neck. So necrotizing enterocolitis, as Dr. Adel said, thank you, is acquired multifactorial devastating gastrointestinal disease associated with high mortality, morbidity, and the cost for the NICU. It's characterized by ischemia, necrosis, inflammation of the bowel, invasion by gas-forming organism, and intrapleural dissection. High mortality, morbidity, and high cost. Long-term complications like strictures, adhesions, cholestasis, short bowel syndrome, failure to thrive, and the most important is the neurodevelopmental disorders. Today I will discuss the epidemiology. I will concentrate on the pathogenesis of the necrotizing enterocolitis because there is something new and it is very important in the prevention. After that, understanding the disease pathology or pathogenesis will help us to identify the kinds or the types of NEC, as Dr. Adel said. It's not one entity now. What is the risk factor? And I will criticize on the risk factor effect on the baby. A clinical presentation, how to diagnose the NEC and the treatment, especially the medical treatment and the opportunity for the prevention. As we know, the majority of NEC patient is preterm babies. 90% of NEC cases occur in the preterm baby, especially the very low birth weight. The incidence is inversely proportional to the gestational age. With smaller or younger gestational ages, the incidence is higher. There is variation in incidence all over the world. Unfortunately, only the high-income countries has good statistics. I try to find in Egypt, to find in Tunisia, whole Africa. I cannot find some reports from Asia only. And we are following the rate of, or the range or the incidence of the high income in countries. The most recent meta-analysis, they found the rate from 2 to 9% and the lower rate in Japan. The pathogenesis, this is a clue here. The pathogenesis is complex, multifactorial, and incompletely understood. The disorder believed to be composite results of intestinal immaturity, immature immunological response, or hyperactive immunological response, gut microbiota dysbiosis, plus genetic predisposition. So what is the gut microbiota? The whole body, harbor trillions of microbial cells whose coordinated action and are believed to be important for human life. Even the newborn, even the preterm have this high number of microbiota. The highest concentration of microbiota actually is present in our GIT. Gut microbiota has a small number of opportunistic or pathogens, and the whole number is commensals or beneficial bacteria. Becoming a healthy threat only is opportunistic if the gut ecosystem is disturbed. And this is called dysbiosis. If there is disruption of the composition with increment of pathogens in comparison to the commensals and the beneficial bacteria, this is dysbiosis. So the abnormal balance of gut microbiota favoring opportunistic and pathogenic bacteria. For few years ago, this theory is not available in this detail. So gut microbiota is very important now. What's affecting gut microbiota will lead us to necrotizing enterocolitis. This is examples for the affection. The first thing is the mood if delivery, cesarean section. We are the baby is not taking the most of the vaginal, his mother vaginal commensals. Prolonged IV antibiotics, empirical antibiotics, H2 blockers are given to the baby, formula feeding if we started formula feeding, and also pathogens in the environment of NICU, our hospitals. This is harder or affecting the microbiota causing dysbiosis. The second important thing in understanding the pathophysiology is the neonatal intestinal barrier. This barrier actually is the physical barrier and immunological barriers. Physical barriers containing extrinsic barrier or intrinsic barriers. Extrinsic barrier is formed of mucin layer. These mucin layers rich in immunoglobulin A and other proteins. Then after this extrinsic layer, we have intrinsic layer. This intrinsic layer is the cells, and between the cells we have tight junction. This is protecting the body flow leaking or translocation of the bacteria. Actually, after that, we have all immunological cells, dendritic cells, macrophage, T helper, T regulator cells, all in the layer. So this is diagram to show what are the problem or the immaturity in this barrier in the newborn, especially the preterm, and also the GIT. The GIT immature, we have decreased peristalsis, we have decreased digestion, we have more decreased gastric acidity, favoring infection, and decreased proteolytic and digestive enzymes. This leads to stagnation of digestion. After that, we have altered decreased mucus coat and altered mucus proteins, especially this is in preterm baby. The tight intracellular or intercellular junction is deficient, altered, with increased epithelial permeability. Also, I have immature mucosal immune system after that we are mentioned before. Increased microvascular tone of the mesentery, harboring or leading to more vasoconstriction and attacks of ischemia. Increased reticulum also present. The most important now, and this is riding in the pathogenesis, is higher expression of toll-like receptors for expression in the epithelial of the mucosa of the intestine. Because as we see after that, we have here this diagram show the pathogenesis or the microenvironment of the intestine. We have opportunistic or pathogenic organisms favored by antacids, steroids, TPN, or formula feeding. They have direct effect through the toxins or direct effect on mucus degeneration. Also, they can pass through the tight junction. This is loose junction and into bacterial transfer. As we see, bacterial translocation cannot be and there is leakage to the system here, to the blood, reaching the circulation. And this is why we have usually septicemia and necrotizing enterocolitis at the same time. On the other side, we have the translocation, the toll-like receptor 4, which is stimulated by lipopolysaccharides of the toxins or the bacteria. This relieving the pro-inflammatory mediators, especially interleukin-8, tumor necrosis lactophin, and platelet activating factors and others. These pro-inflammation pass to the blood and causing the toxic effect. Both of them affect the damaged endothelium and cause vasoconstriction. We have translocation of bacteria, we have pro-inflammatory inflammation. These pro-inflammatory cytokines which pass to the blood has effect on the brain, and so we have a composition of prematurity affecting the immaturity of the intestine in the form of motility, digestion, circulation, barrier function, and the immune response, all of them leading to the neck. In the presence of dysbiosis, which help in occurrence, we have genetic predisposition. Genetic predisposition is supposed actually in the expression of the toll receptors and the immunomediators. This is why some babies have the same circumstances, and some develop neck and the other do not develop neck. So the risk factors 100. We know prematurity is a disease. Neck is a disease of prematurity. 90% is preterm. Enteral feeding. 90% of necrotizing enterocolitis cases has 1 feed minimum. Low Apgar score, less than 7 at 5 minutes. Body temperature at admission or at 1 hour age, 36 or less. The baby delivered cesarean section at risk. Also, if we give H2 antagonist exposing to empirical antibiotics, sepsis, nootropic support, severe metabolic acidosis, BDA, gastroenteritis, severe anemia, polycythemia, bagged RBC transfusion is a risk factor. Use endomethacin with or without dexamethasone. These risk factors still mentioned in the preterm baby. What about the full-term baby? Full-term baby, actually, we have risk factors different in the full term. As we said, we have like 10% of NEC cases can occur in full-term babies. We have fetal growth restriction, this is the most important, exposure to perinatal asphyxia, formula feeding, pre-existing illness, such congenital heart disease, primary gastrointestinal disorder, sepsis, hypotension, and polycythemia. As you noticed, hypoxic ischemic encephalopathy is no more one of items in the pathophysiology or pathogenesis of NEC in the preterm babies. It's accepted if occurs in full term, but preterm babies has his explanation or pathogenesis process. We have common pathogens. Actually, not all cases we can isolate pathogens, but most commonly is enterococci. As you know, E. coli, Salmonella, Enterobacter, and Klebsiella. Staphylococcus species also, Clostridium species. Sometimes we have viruses like 10%, Candida in like 1%, and no organism isolated in 3% of cases. So I will try to make it very interactive now to brainstorm ourselves. I have a problem. Yes, okay, like this. So what is the relation between the empiric antibiotics and NEC? So we are discussing now the risk factors. So the empiric antibiotics, the empiric antibiotic exposure for 5 or more days in preterm neonates before 29-week gestation was associated with the increased risk of necrotizing enterocolitis. Sorry. threefold increment in the risk of necrotizing enterocolitis in infant receiving cumulative antibiotic treatment for more than 10 days in the absence of sepsis. This is very important because we can prevent this. So the most common talk now about the backed RBCs transfusion. Can backed RBCs transfusion cause necrotizing enterocolitis? So many observational studies reported temporal relation between the RBCs and transfusion. They noticed the presence of 25 to 40% of all cases with valve NIC occur 2 to 48 hours after having backed RBCs transfusion. Risk of NIC may have been higher in infants who severely anemic before transfusion. Now we have what's called transfusion-associated NIC term. It is maybe different entity, like Dr. Adil said at first. However, can backed RBCs transfusion cause NIC? Other studies in the country found no relation between the backed RBCs transfusion and the NIC. Even they report severe anemia defined as hemoglobin like 8 grams per deciliter is in a given week was associated with a higher risk of necrotizing enterocolitis. So every team of these researchers has his justification. So in transfusion associated, the mechanism could be immune mechanism. The blood has the blood transfused has antibodies, biologically active lipids, free hemoglobin, red cells, membrane fragment, and the inflammatory cytokines present in the stored blood. Also, we can explain by reperfusion oxygen injury of the anemic gut. Elder RBCs can accentuate the microvascular ischemia and tissue hypoxia. In contrast, the anemia can affect the perfusion, tissue hypoxia and aerobic metabolism, impaired normal maturation of vascular autoregulation of preterm babies. If you are worried about backed transfusion, should we withhold feeding during the RBCs transfusion? I don't know who's practiced this in his units, but many units now, after hearing that transfusion is associated with NIC, after reported increased NIC, after they implement the withholding of feeding during or before and after backed transfusion. This is a study from George Washington with Dr. Hani Ali reported that the incidence of NIC decreased after withholding the feeding during backed RBCs transfusion. However, the Cochrane, this is Cochrane is in 2019 about stopping enteral feeding for prevention of transfusion-associated necrotizing enterocolitis. They concluded randomized controlled trial evidence is insufficient to show whether stopping feeds has an effect on the incidence of subsequent necrotizing enterocolitis or death. And they recommended large, adequate powered randomized control study are needed to address the issue. So this is not large randomized control study, but it's randomized control study, but with a small numbers. This is done in Australia and published 2020. It is FEED-YOUR randomized control trials. They concluded there were no difference in splanchnic oxygenation when enteral feeding were either withheld, continued, or restricted during transfusion. They have three groups. One group, they withhold feeding during transfusion and before and after. The other continue the same feeding. And the third group, they restricted the fluid, the feeding intake to 120 ml only per kg per day, the total feeding. They found no difference in the oxygenation or perfusion as splanchnic. However, this is small very numbers. I think the total is 60. And there is two randomized control studies running about this issue. As we know, the 90 8% of the preterm babies has feeding lag. This is starting feeding early. So should we delay the start of enteral feeding to decrease the incidence of necrotizing enterocolitis? It is different if we started the first day, second day, or later. So among extreme preterm neonates, those who develop NIC were MPO for a longer period of time than control infants who are NIC-free. Keeping the patient MBO longer than 5.5 days were more likely associated with the stage 3 NIC, perforated NIC, longer duration of mechanical ventilation and ICU admissions, a higher mortality and the incidence of bacterial sepsis. So we will try to start all support to try as early as we can. Delaying feeding don't protect the baby from ICU NIC. The second question is, early enteral feeding increase the risk of NIC? If we started early feeding, this increase the risk of NIC? Cochrane Review 2013 found there is no difference in the incidence of NIC when beginning trophic feeding early within the first 4 days of life and continued them for 1 week compared to fasting group. No difference. A more recent study, meta-analysis and randomized control study, both published in 2019, no difference in the incidence of necrotizing enterocolitis or feeding intolerance when starting early total enteral feeding. Decrease incidence of late onset sepsis and the length of stay, this is extra advantage. So starting early feeding now is accepted. So we started feeding. Should we increase the amount or volume rapidly or very slowly? Is rapid feeding increment increases the risk of necrotizing enterocolitis? We have what's called control trial for 2 incremental milk feeding rates in preterm infants. Actually, this is published 2019. We have milk feeding rates. We have 2 groups. The first group feeding 30 ml per kg per day increment. The second increment group was 18 ml per kg, and this was the standard. The primary outcome actually in this study was the survival without moderate or severe neurodevelopmental disability. No significant difference, however, it is low actually in the rapid group. As regards the necrotizing enterocolitis, no significant between group difference in confirmed or suspected late onset sepsis or early stage 2 or 3 necrotizing enterocolitis. So feeding with increment 30 ml per kg per day is still not causing a higher rate of NIC. So the next question, when the start feeding, this is a very important issue. When to start the enteral feeding in a small for gestational age with abnormal Doppler diastolic rate. Actually, most of the unit till now practicing to wait for how long it's different for 3 days, 5 days, or no. Randomized control trial conducted to compare early feeding in the first after the first 2 days versus delayed after 6 days in small for gestational age preterm, not only small for gestational age, but also preterm infants with abnormal antenatal Doppler ultrasound, either absent or reversible diastolic fluid. The mean gestational age of the group was 31 weeks. The number of the patient was 380 infants. They found that the early introduction of enteral feeding in the small for gestational age preterm infants results in earlier achievement of full enteral feeding and did not appear to increase the risk of necrotizing enterocolitis. However, when they analyzed the subgroups and comparing the babies less than 29 weeks and the elder paper, they found the baby who less than 29 week gestation achieved the full feeding were later, 28 days versus 19 days for elder babies, or elder babies as regard the gestational age. Also, significant higher incidence of all stage of necrotizing enterocolitis, very significant, almost 39 versus 10. So hence the author concluded that a slower advancement of feeding may be required for this population. We have to remember in this study we are using breast milk expressed either the mother breast milk or the donor breast milk. So what is the time of onset? This is some discussion with the risk factors. Usually the onset is related to the gestation. The onset of necrotizing enterocolitis is inversely related to the gestational age. The earlier the gestational age, the later the chronological age at which the necrotizing enterocolitis occurred. The average age at onset is 20 days if the baby born before 30 weeks, almost to 2 weeks if the baby born between 31 and 3 weeks gestation, and 6 days if the baby born after 36 weeks of gestation. Clinical pictures of the necrotizing enterocolitis, we have, if we need to diagnose, we have thinking about clinical pictures and radiological and the laboratory. The clinical pictures, we have systemic manifestation and GIT manifestation. Please, during your round in the NICU, search for both, because sometimes we have only GIT manifestation without systemic manifestation, and the reverse occurs. No need to stop feeding for baby with sepsis, and they have no GIT manifestation. No need to start investigation for neck, and the baby is clinically well, no systemic manifestation, and only have some residual or abdominal distension. So the systemic manifestation is lethargy, apnea, respiratory distress, bradycardia, temperature instability, metabolic acidosis, poor perfusion, hypotension, shock. So this is sepsis-like picture. However, the GIT manifestation, we have abdominal distension, feeding intolerance with increased gastric residual, vomiting. We can have gross blood bleeding the rectum or occult bleeding. Occasionally there is diarrhea, abdominal wall erythema in severe cases, abdominal tenderness, and decrease or absent bowel sounds. When you suspect that the baby is necrotizing enterocolitis, we have to do laboratory studies. We are doing CBC, searching for leukopenia, leukocytosis, neutropenia, neutrophilia, elevated immature total neutrophil count was shifted to the left, thrombocytosis, thrombocytopenia, sorry. Higher or rising C-reactive protein. Full septic workup should be done, as most of the cases of necrotizing enterocolitis with translocation of bacteria could have sepsis also. We'll do blood culture. If the baby is stable, do CSF culture and analysis, urine culture also. Blood gases, searching for metabolic acidosis and combined respiratory acidosis. Renal function test to check the perfusion of the kidney. Electrolytes to check the hyponatremia especially and the potassium level. Coagulation profile, and the baby is more vulnerable for DIC. If we have peritoneal fluid, we should show the fluid for analysis, culture, and sensitivity also. The abdominal X-ray, that remains the modality of a choice for diagnosis of necrotizing enterocolitis, but clinical correlation is very important because we have other diseases have the same finding of the X-ray on necrotizing enterocolitis and a different diagnosis. So clinical correlation is important. Standardization of X-ray interpretation aim to reduce the number of babies subjected to periods of suspended oral feeding, as we said, early and timely institution of medical therapy in cases of necrotizing enterocolitis. So I recommend this topic to read. This is published in the Archive of Disease, Child Education, Practical Edition. It is published in 2019, and it is free access. A very nice topic about the X-rays and the sign. I will mention some of them here. So what are the position you request? When you are called the technician, what's the position for the X-ray you will request for the baby? This is very important in our usually we should anteroposterior. Then we should ask for left lateral decubitus. This left lateral decubitus, the baby is sleeping on his left side and the right side is up. Because if we have pneumoperitoneum, we can see the air leak here. As you see, the cassette in behind the baby and the beam come from front and the baby on the left side. If the baby is not able to move and connected like to high frequency or something, we can do a lateral cross table. The same technique, but the baby is sleeping is his back, so supine position, and the cassette beside the baby. This is very important. Left lateral decubitus. Searching for what in the radiological finding, we may have dilated lobes, we have second wall, decreased gas of the abdomen, fixed dilated lobes, ptosis intestinalis, portal vein, gas, and pneumoperitoneum. This X-ray show dilatation, abnormal dilatation of the gases, and we have some thickening the wall. Thickening of the wall, actually, here's some people say this is matter of fluid in the peritoneum and separating the os intestine from its side and give the look of thickened wall. But the best modality to check the wall thickening is ultrasound we discussed before. The second is a pneumatosis intestinalis. Pneumatosis intestinalis, as we discussed in the pathogenesis, with translocation of gas-producing bacteria, we have intraluminal gas. These intraluminal gases we'll see in the X-ray like this. You see this arrow here also, here also, here can be very extensive, occur as in the left slide or the right slide in the intestine stomach wall, the whole intestine, as you see. This is pneumatosis intestinalis. Yes, on the other side. So it can like ring or curve or line according to the end-on or the X-ray beam. So this is the pathogenesis of pathology of pneumatosis intestinalis from the lumen with translocation of gas-producing bacteria. We have here submucosa and even sometimes subserosa. This is the pathology. Portal vein gases, in severe cases, we have like portal vein gases. Take care, this is a transient, sometimes you see and disappear. And this is raised the modality of ultrasound. Portal vein thrombosis. It is omnia sign. This means we are dealing with severe case of neck. We have fixed loop with another omnia sign, and this means there is necrosis or gangrene of the intestine. This post studies for the same baby was 48 hours apart. This is from the Atlas of Pediatric Surgery, published in 2020. We have the same fixed loop. Even if we have no pneumoperitoneum here, this is a very surgical cause because we suspect that we have necrosis in the intestine. So the pneumoperitoneum, this X-ray for the same baby, we have anteroposterior diameter. As you see, his translucency in front of the liver. It is not like the in front of the liver, but when we take a position of left lateral decubitus, see how much the air and displacing the liver down for the same baby. So sometimes in anteroposterior X-ray, the minimal pneumoperitoneum may be missed. This is another pneumoperitoneum, also the same patient. Here we see displacing the liver around the liver on the left side. This is anteroposterior for the same baby. sorry, different baby. We have what's called football sign. If you see, this is the air around pushing the whole peritoneum inside. This is severe pneumoperitoneum with football sign, the American football also here in the right side. So now we have riding chances for bedside ultrasound and the Doppler ultrasound. It is more dynamic, more sensitive for detecting peritoneal fluid collection, especially the minimal, moderate, permit real-time visualization of the bio-wall thickness. It's better than X-ray. Peristalsis, and they help us in the presence of necrosis, and perfusion by the Doppler ultrasound. It is more sensitive than abdominal radiography in detecting bowel necrosis through the peristalsis and the perfusion. As we know, it is operator dependent. So we reach to the modified Bailey staging. Modified Bailey staging, like 40 years ago, this is the bill announced for this staging at 1978, and after 9 years was modified by Walsh. They classified at grade 1, grade B, stage 2, and stage 3. So stage 1 is suspected. We have systemic manifestation with very minimal gastrointestinal manifestation. The X-ray is normal or just dilated loops. If we have gross bloody stool, this is stage A, B. Stage 2, this is a definite or diagnosed medical necrotizing enterocolitis. The baby is mildly ill. We have temperature stability, apnea, lethargy, sepsis-like picture, but with increasing the abdominal signs. We have decreased or absent bowel sound with or without abdominal tenderness. X-ray here we have pneumatosis intestinalis plus dilated loops, fixed loops. So definite moderate L اللي هو P. So the P we have systemic manifestation, mild metabolic acidosis and mild thrombocytopenia. In the GIT manifestation, we have tenderness plus absent bowel sound with and without abdominal cellulitis and erythema. We can feel at this stage mass in the right quadrant area. X-ray changes, we have plus the abdominal tenderness, bowel sound without, sorry. So stage 3, this is surgical or advanced neck. We have A and B also. If we have pneumoperitoneum, we are going with B. Actually modified, the question now in the researchers, the modified Bailey staging can survive. Joseph knew it is the father of neck, now said outdated. It is more informative to simply use the term of medical neck to apply the condition with well-defined clinical symptoms plus radiological signs like pneumatosis intestinalis or portal gas vein, venous gas. And the second is surgical neck to apply to definitive intestinal necrosis seen at surgery or autopsy. Actually, most of the researchers are now speaking in their studies about stage 2 and stage 3. They didn't mention stage 1 of Bailey staging. And some papers now mention the management like this. So what is the differential diagnosis or the disease mimic the necrotizing enterocolitis? We have a very famous spontaneous intestinal perforation, ischemic intestinal necrosis, food protein or cow allergy-induced enterocolitis syndrome, congenital anomalies of the bowel that mimic neck. The most famous is spontaneous intestinal perforation, characterized by single non-inflammatory perforation. In contrast to the necrotizing enterocolitis, it has multiple perforation surrounded by high inflammatory reaction, typically located in the terminal area or colon. Primary occurs in infant less than 1 kilogram. The pathophysiology is not totally understood. Giving some medication like steroids or non-steroidal anti-inflammatory medication may increase the risk. How to differentiate from the neck? Less severe systemic signs. Again, remember the criteria of diagnosis. Earlier age of onset, absent of pneumatosis intestinalis and portal venous gas. The perforation has minimal surrounding necrosis or neutrophil infiltrates. Although both of them need surgical intervention, but it's very important because it affects the prognosis even in management. The second is ischemic intestinal necrosis, and this is usually occur in term babies and the preterm also occurs with the baby's congenital heart disease like hypoplastic left heart syndrome, truncus arteriosus, severe aortic coarctation, and aortopulmonary window. All these diseases affect the perfusion of the gut. We have a splanchnic ischemia. The colon is the most commonly involved site, proposed to be secondary to splanchnic ischemia, as we said. The food protein-induced enterocolitis syndrome, or like cow milk allergy, it occurs in the artificially fed infants, occur if in term and preterm infants, present with abdominal distension, bloody stool, flank discoloration, non-pneumatosis intestinalis, improve after being treated with hydrolyzed formula, may have eosinophilia and thrombocytosis. Actually, this is occur usually in infants, larger infants, but there is many cases now, case series reported in ICU, in neonatal. Sorry, going to the reverse. The other presence of congenital anomalies in the bowel that mimic necrotizing enterocolitis. We have the Hirschsprung disease. Hirschsprung disease has a very characteristic X-ray usually and presentation, usually earlier presentation. But the problem, sometimes we have what's called inflammatory enterocolitis because the stagnation in the colon, we have inflammatory enterocolitis, and this is similar to necrotizing enterocolitis in the picture. And they have high morbidity. We have abdominal distension, vomiting, rectal bleeding. Also other intestinal obstruction due to volvulus or intussusception or meconium ileus even may have the signs like neck, but usually earlier. And sometimes we have pneumatosis intestinalis in these conditions. It's very important to take care for the condition mimic necrotizing enterocolitis. They sometimes say this is different entity of a neck. So how to manage the baby with necrotizing enterocolitis after diagnosis? We have principle for medical management. Just keep MBO with bowel decompensation or decompression. Start total parenteral nutrition and the fluid, respiratory and cardiovascular support, antibiotic therapy, blood product and fluid resuscitation, serial laboratory and radiological monitoring. And this is very important for the X-ray. We repeat the X-ray every 6 hours, sometimes every 12 hours, according to the stage of the necrotizing enterocolitis. Also, we need serial lab to follow up the platelet, to follow up the coagulation profile, to follow up the electrolytes. This strategy for the management plan, stage 1 antibiotic plus MBO for 3 days and follow up with the X-ray, and clinically stage 2 MBO for 7 to 14 days according to the stage, and start TBN also. Stage 3, usually we need fluid resuscitation, inotropic support, ventilatory support, and the blood product like platelet transfusion and fresh frozen plasma. Stage 3, we need surgical we need surgical management. So I will talk about the antibiotics. We will start or change the antibiotic to empiric broad spectrum antibiotics. Please follow up. Take care based on the common organism in your unit. What's suitable in United States, not suitable in Egypt, not suitable in Tunisia. even in different units in the same country, we have failed. I know that the Klebsiella is in my unit, so I will start something against Klebsiella. The suggestion of ampicillin, gentamicin, or amikacin, clindamycin, or ampicillin or ceftazidime instead of cefotex. Sometimes we start طبعا mironium vancomycin if we are suspecting methicillin-resistant staph. Metronidazole or clindamycin is added to cover the anaerobic bacteria. Surgical management, please involve the pediatric surgeon from the start. Even from stage 1, yes. Once you suspected necrotizing enterocolitis, involve the pediatric surgeon in management. We have absolute indication for surgery in the intestinal sound. This will be discussed by Dr. Amin. But keep in mind, the perforation can occur without evidence of free air in the radiograph, especially in the extreme preterm. So if you are searching for pneumoperitoneum, sometimes we have perforation without pneumoperitoneum. 50 to 75% of perforation only have pneumoperitoneum proved in the X-ray. Sometimes gasless abdomen is going with. We have relative indication for surgical management. Like erythema in the abdominal wall, gas in the portal veins, fixed bowel lobes. This is very important because we suspect ischemia, positive paracentesis more than 1 centimeter, especially if there is fecal matter, clinical deterioration, and this is a debate usually between us and between the pedia surgeon. Dr. Amin will discuss this issue. Worsening and deteriorating clinical condition, not improving, with sign of peritonitis, intractable acidosis, intractable thrombocytopenia, increase the lactic acid. This is very important. One of the follow-up usually in the lab, we follow lactic acid if you it is available, especially in the blood gas machine, if you have blood gas machine with lactic acid. So can we prevent the necrotizing enterocolitis? Yes. This is understanding the pathogenesis will help us in the prevention. Prevention can start from antenatal. If we can postpone the preterm delivery, this is well and good. If not, we should receive antenatal steroid because it decreases the neck, IVH, RDS. Natal, during resuscitation, delayed cord clamping, potentially it will prevent the anemia and also decrease the need of backed RBC transfusion. And this is direct will protect or decrease the risk of neck indirectly. Good thermoregulation during transport and avoid hypothermia. Postnatal colostrum and the breastfeed is the magic shield against the necrotizing enterocolitis. Standardized feeding guidelines, this is very important. Many studies show that the standardized feeding protocols decrease the risk of necrotizing enterocolitis and the incidence of necrotizing enterocolitis. Avoid or shorten duration of empiric antibiotic therapy. Don't leave the baby with antibiotic because he's on CPAP, because the baby don't reach full enteral feeding, because the baby still have UVC. Once you have negative culture of CBC, CRP, not suggesting infection, stop the antibiotics, please. Avoid antacids and H2 blockers. Standardized RBCs transfusion. So breast milk and milk, we have nutritional and non-nutritional anti-infective properties, helping in protection of the babies from necrotizing enterocolitis. The incidence of necrotizing enterocolitis is described to be 6 to 10 times higher in formula-fed baby when compared to breastfed baby. This is since 30 years ago, and there's the research supporting the presence of materials or substance in milk, especially immunoglobulin A and human milk oligosaccharides, probiotics, something like this. This is proposed mechanism for prevention of neck by the human milk Also, with the anti-infective property, the human milk improve the barrier function, improve the growth of the mucosa, and increase the proteolytic enzyme, improve the peristalsis, and increase the number of immunoglobulin A, lactoferrin also. So tecomazid, usually the best, remember all the time. The second rising star in the prevention is the probiotics. It is live microorganism, produced bacteriostatic and bactericidal substance, prevent colonization of pathogens by competing for adhesion to the intestinal mucosa, or the gut microbiota, favoring the non-pathogenic bacteria. Prophylactic probiotic reduce the incidence of necrotizing enterocolitis, especially that of severe cases in infant less than 1.5 kilogram. This is proved in multiple studies. However, the probiotics trial still controversial. Trials are difficult to generalize as mean use. We have different study design, different probiotic types, different infant diets. So breast milk, donor milk, mixed or artificial, different feeding times. Also, we have different types of probiotics. We have different types, and some studies use only one anti-probiotics, and other studies used one or more probiotics. So we are still waiting for further studies. There are conflicting opinions also about giving live bacteria to vulnerable preterm babies. Thank you very much.
Thank you very much, Professor Mustafa, for this very interesting and exhaustive lecture. I may ask Professor Adel Riyaz to give us just a take-home message.
Right. Thank you very much, dear Professor Mustafa, for such a wonderful presentation, very comprehensive, very practical, answering the myth, a lot of myth about necrotizing enterocolitis and feeding of the preterm. Actually, the major problem is that, I'll tell you something, the full-term baby is during intrauterine life is swallowing 150 milliliters per day. So if the weight is 3 kilograms, he is swallowing almost half a liter of amniotic fluid every day. And after delivery, we stop everything, we leave him to starve, and this is very dangerous. Never leave the gut empty. That's why the golden hour is very important. To start breast milk as soon as you can, as long as the baby is stabilized, start breast milk. This is the golden standard. This is the magic protection against a lot of problems in the neonatal intensive care. So when we start early, the breastfeeding, when we avoid the antibiotics are a disaster, really a disaster. The cesarean section, we give antibiotic. Normal delivery, we give antibiotic. The baby in the intensive care receives antibiotic. We are creating the dysbiosis by ourselves. That's iatrogenic. This is very serious. The prolonged courses of antibiotics, we should avoid. This is really, there's a lot of studies about the duration of the antibiotic use and the mortality. I'm not talking about complications, I'm talking about the mortality. The mortality is higher with the longer courses of antibiotics. So please start as early as you can the breast milk, the first thing to go into the gut of the preterm baby is the breast milk. Start to try to avoid antibiotics for the women after delivery as much as you can. Try to avoid antibiotics in the neonatal intensive care as long as you don't need it. In our unit, we used to give ampicillin gentamicin for 2 days, and we stopped the antibiotic as long as the culture is negative. CBC and CRP are okay. But now we are trying even to avoid the double antibiotic. We use one antibiotic. Even sometimes we don't use antibiotic. We wait and observe the baby closely and see how it goes. Trying to avoid antibiotic will help a lot in saving a lot of children. Don't think that antibiotics will save the baby. It's a hazard. Really, it's a hazard. Definitely, it will save the baby if there is infection, but if there is no infection, there's a lot of harm we're doing. Dysbiosis, this is very important. This is a very important issue. So please, gut dysbiosis is very important. Early is very important to avoid. Early introduction of breast milk, this is extremely important. The myth of the umbilical catheter, the myth of giving the blood transfusion, the myth of endomethacin, we do not stop enteral feeding. Enteral feeding is becoming more important than parenteral. You start early enteral feeding to achieve full enteral intake in 1 week in the infants, 150 grams, 1,050 grams, 500 grams, and in infants, 1,000 grams in 2 weeks maximum. So enteral feeding should start early to remove the parenteral nutrition with all the complications that we can see from the parenteral nutrition. It's very important. Early enteral feeding, avoiding the antibiotics, use of the golden standard, the breast milk, and I think this is the most important thing to remember: avoidance of the antibiotic, giving the breast milk. This will save a lot of our children. By the way, hand washing, seriously, hand washing is important, is extremely important. I used to do that years ago, before the era of hand washing and the infection control and so on. I used to do that, I would say, from the early 90s or late 80s, maybe. Hand washing is extremely important before and after examining the baby. You will reduce the incidence of infection in your unit. It's extremely important. That's all. That's enough. Thank you very much indeed. Thanks a lot. Sorry for being so... Okay, thanks a lot.
Thank you very much for all those comments. And now that we have listened to the medical management of NEC, let's move to the surgical side of this condition that requires the efforts of both neonatologists and pediatric surgeons. For that, Professor Amina Qsia will present the second lecture called Surgical Management of Necrotizing Enterocolites. Dr. Amina Qsia, you are welcome. He is a Tunisian Pediatric Surgery Associate Professor working in Fatouma Bourguiba Teaching Hospital in Monastir and teaching in Medical School of Monastir. He worked also in Hospital Armand Trousseau and in Hospital Bicêtre in Paris and in El Hadda Military Hospital in Saudi Arabia as consultant pediatric surgery. Dr. Amina Qsia is currently a board member of many scientific associations, International Pediatric Endosurgery Group Middle East Chapter, Pediatric Adolescent and Adult Forgot Interdisciplinary Symposium, the Tunisian Association of Pediatric Surgery, the Tunisian College of Pediatric Surgery, and Tunisian Association of Neonatal Care, which organizes this webinar. He is also Monastery Medical School Vice Dean. So, Dr. Amin Qsia.
Many thanks, Professor Sonia Nouri, for this kind introduction. This is really my pleasure and honor to be part of this nice webinar, and I would like to thank very much all the honorable audience. I would like also to thank our two prestigious guests, Professor Adel Riyad and Professor Mustafa Abdelazim. We really enjoyed your lecture, Professor Mustafa. And special thanks for all my friends in the Tunisian Neonatal Medical Care Association Board that gave me this opportunity to speak about the surgical management of necrotizing enterocolitis. I don't know if you see my screen.
It's very clear.
Yes, okay. So I was really excited of the subject because necrotizing enterocolitis is one of the commonest neonatal surgical emergencies that do need timely assessment and action in order to reduce the morbidity and mortality. It's true that the advances in the neonatal intensive care and the availability of total parenteral nutrition resulted in fewer infants requiring surgery. But surgery is still indicated in approximately 1/3 of all diagnosed cases. And you must know that the overall mortality from NEC is estimated at 15 to 30%, but rises as much as 50% in the patients who require surgical intervention. This surgical intervention can be done in the early period in order to reduce the degree of contamination and sepsis, with preserving an adequate length of bowel to prevent short gut syndrome. Surgery Here, I will discuss the key point in the success of NEC management. It's the relationship between the neonatologist and the pediatric surgeon. And this relationship should not be conflictual. You know, sometimes the pediatric surgeon can think that the neonatologist is pushing him to perform the surgery, even if it's not indicated. And on the other hand, the neonatologist can think that the pediatric surgeon is escaping from his responsibility. So instead, we must have a trust relationship. And to have a trust relationship between these two main protagonists, we should fix clear rules in the management of NEC. And these rules will depend on two things. First of all, the scientific data. But also, we should adapt this scientific data to our local conditions.
Sorry, Professor Amin, we can't see these slides.
Can you share your?
We can't see it.
Screen, please?
We only saw the first slide. Otherwise, we can see it.
Is it clear now?
No, it's not yet.
So I will share again.
Yes.
Yes, please.
Do you see it now?
Not yet, but it's coming. I can see it. I don't know if anybody else can see it or not.
Yes.
No, we can see it now.
Okay. Okay, so I will return to this key point in the management of NEC. It's the relationship between the neonatologist and the pediatric surgeon, and this relationship should not be conflictual. As you know, sometimes the pediatric surgeon can think that the neonatologist is pushing him to perform the surgery, even if it's not indicated. And in the other side, the neonatologist can think that the pediatric surgeon is escaping from his responsibility. So instead, we must have a trust relationship between these two protagonists. And to build this trust relationship, we must fix clear rules in the management of NEC. Those rules will depend on two things. First of all, the scientific data, and this scientific data should be adapted to our local conditions. You know, personally, I worked in 3 departments in 3 different countries, and I can tell you that the management of NEC is different. It's not only a question of money. Money is very important, the material that is available and so on, but also there are other factors like the availability of pediatric surgeon in your center, or also some ethical and cultural issues. Now, regarding the scientific data, the major concern that is always debated between the pediatric surgeon and the neonatologist is the selection of patients for surgery. And now it is well established that in the early period, there are clear indications that are the intestinal perforation that you can see sometimes in the X-ray with pneumoperitoneum, or the lack of improvement despite optimal medical treatment. And here the classification of Bell is very useful to know this patient. It's the 3B stage in this classification. Also, the time to operate is very important to prevent severe complications. And here we should know the risk factors. And there are well-known risk factors that was done by my friend, Professor Mustafa, like the persistent and worsening pneumatosis on serial radiographic examination, the presence of the portal venous gas, the sudden hyponatremia, the sudden acidosis, or a profound sustained drop in the platelet count suggestive of gangrene. But we found a lot of papers that are talking about some new predictive factors, like I found this in this article that was published in 2020 in the European Journal of Pediatrics. So they are speaking about the low gestational age, non-maternal corticosteroid administration, the early onset of NEC, hemodynamically significant patent ductus arterius for which ibuprofen was administered. We can find also updates in the use of ultrasound to predict bowel gangrene in absence of pneumoperitoneum, and this criteria include the fluid quantity, the bowel thick of the wall, and also the bowel wall echogenicity and the bowel perfusion, like you see in these examples. Regarding later surgery, here the indications also are clear. As you know, in NEC we have ischemia, and ischemia can lead to stricture and also to fistula. The diagnosis would depend on clinical feature, but it will be confirmed in the enema contrast study, as you see in this example. Here we have a stricture in the contrast study enema, and here we have an iliosigmoid fistula. This is a picture that I take from this nice book written by our friend Sherif Emil. And the treatment for these two complications is the resection anastomosis. Usually it's done after 6 weeks of the onset of NEC. Also, later surgery can be done to restore intercontinuity, and also here the enema contrast study is very useful to check if there is any stricture below the stoma, and also later surgery can be done in centers for intestinal transplantation. You must know that NEC is one of the indications of intestinal transplantation for short gut syndrome, but the results are not promising. Now, what about the surgical options? Regarding the surgical option in the early period, we will have 3 ones. First of all, the laparotomy. Second, the peritoneal drainage. And third, the peritoneal needle suction. Let's begin by our first option. Laparotomy will have the advantage to let us to explore the viability of the bowel. Also to perform the lavage in order to decrease the effect of toxin. And you must know that the standard treatment with laparotomy is resection of necrotic bowel and stoma formation. However, your strategy will depend on the baby statement. Is he stable or unstable? And it will depend also on the lesions that you will find. So let's take some examples of the lesions that you can find in the laparotomy. You can find, like in this example, a good viability of the bowel, and here you will perform a lavage with drainage. Second constatation, you can find focal lesions, and here you will perform a resection of the necrotic bowel. And after, you have two options. You can perform a stoma or an anastomosis, and each option has its advantages and disadvantages. Surely stoma is the safest option, but you can have complications like fluid and electrolyte imbalances, prolapse, retraction, skin excoriation, or wound breakdown. And here you will need for future reversal surgery. For the primary anastomosis, here you will not need, a future reversal surgery, but you can widespread systemic inflammatory response, and you are exposed to complications like leak, stricture, especially if you have a frail bowel. Third constatation that you will find, and you can find after laparotomy, is multifocal neck. And in this case, the patient is too unstable to undergo resection. And there is a significant risk of major bleeding. So here you will proceed to a salvage technique to stabilize the neonate. You can perform a proximal diverting jejunostomy, but here the fluid and electrolyte loss can be troublesome. Or you can proceed with a wait and see approach. So you will make a lavage and you make a second look after 2 or 3 days to assess again GUT's viability and to perform limited resection to avoid short gut syndrome. Or you can perform the clip and drop technique. So here the gangrenous bowel segments are resected with the ends tied off. The bowel with questionable viability is retained, and you will relook to the perform a relook laparotomy after 2 days to determine the true extent of the disease. So further segments affected can then be resected again, and the stoma plus minus anastomosis can be performed. Here, the advantages of this technique is to control the initial sepsis and to avoid unnecessary extensive bowel resection. The fourth constatation is pan-intestinal lesions. So here you will perform lavage and drainage with jejunostomy or clip and drop or wait and see approach. In some cases, you can have difficulties to close the layers, and you can perform a laparostomy with vac dressing. Here we arrive to the most serious constatation. It's really a nightmare for a pediatric surgeon when you find a total intestinal gangrene, and here you don't have any other option than the withdrawal of treatment. Here we summarize all the options that we can find after a laparotomy. Now we will move to our second option. It's peritoneal drainage. Peritoneal drainage was described for the first time in Toronto for unstable babies. And we remarked that this baby survived without any surgery, or at least they improved and led us to proceed after to laparotomy in better conditions. The peritoneal drainage had advantages to remove the toxic effluents, to decompress the abdomen, to improve the respiratory condition and promote spontaneous healing. And also the big advantages, the procedure is quick. You can do it even in the bedside with less complications risk. In the literature, the success is between 20% to 80% with drainage alone. And this difference will depend on the patient selection. but you can find this unmissable article that appeared in the New England Journal of Medicine, and it's a very well done article. And here, there is no doubt, peritoneal drainage and laparotomy give the same results for this patient with severe neck. So here I will return to the local condition. We in Monastir, we are now attempting to perform drainage, because we have in charge a lot of centers that are far from Monastir, like Sousse or Qirwan or Mahdiya. So we prefer to make the surgeon move to the patient instead to make the patient move to the surgeon, and with the transplantation risk that you know. The third option is the peritoneal needle section. Peritoneal needle section was described for spontaneous intestinal perforation. And here it's debated. Dr. Mustafa spoke about this. Some will consider spontaneous intestinal perforation as part of neck. Others will consider it as a specific disease, a particular disease, especially it's affecting a special population. Here we will perform a punction of the right hypochondrium with exsufflation of air and fluid. Two final points that I will develop. First of all, the place of laparoscopy. As you know, in laparoscopy, we will require the use of carbon dioxide insufflation to create a pneumoperitoneum, which may negatively impact on the pathophysiology. So we should need a careful patient selection. The other point is the management after primary surgery. So we'll begin by parenteral nutrition till optimal healing. It can you can obtain this optimal healing after 7 to 2 days, but this should need daily evaluation, and enteral nutrition will be introduced after consultation of neonatologist and surgeon. Here we will come to our take-home message. First of all, the absolute indication for surgery is intestinal perforation. There is a role for bowel resection and primary anastomosis in limited neck. An enterostomy is the usually preferred approach, but should be weighted up against the stoma risk. Severe neck can be managed with a high proximal jejunostomy or using the clip and drop technique. And there is limited evidence of the role of laparoscopy in neck. Peritoneal drainage is a good option, even considered by some as only a salvage procedure, whereas others have used it successfully as definitive management. And my final conclusion would be the key point in the success of the management of neck is, first of all, the trust relationship between the neonatologist and the pediatric surgeon, because at the end we are only one team and we have the same goal. And the best treatment is the prevention of neck and prevention of severe form of neck. And here it was really well developed by Dr. Mustafa. We are speaking about breastfeeding, about probiotics, and so on. Thank you so much for your attention, and I hope that you will visit us soon in Tunisia just after this pandemic. You are really welcome in Tunisia. Thank you very much.
Thank you. Thank you very much, Professor Amin Qsia, for this interesting lecture about surgical management of necrotizing enterocolites. If there are any comments or any questions, we will discuss them at the end of the session. And now I invite Dr. Manal Billallah to present her clinical case, necrotizing enterocolites in a premature infant, a challenging situation. Dr. Manal Billallah is an associate professor in our department, in neonatology department at Farhat Hashed Hospital in Sousse. She is also teaching in Faculty of Medicine of Sousse. Manal.
Thank you. Good evening, everybody. Thank you, Professor Nouri. And before I begin, I would like to thank the Tunisian Neonatal Medical Care Association for giving me the opportunity to present my clinical case. And this case will illustrate what has been said in the previous presentation.
You share your screen?
Yes.
There will be some questions, and the participants can answer those questions.
Necrotizing enterocolitis in a premature infant was a challenging situation, and our patient was Shifa. She was a female newborn, issued of triplet pregnancy, born at 30 gestation weeks by a 30-year-old mother, prima gravida. The pregnancy was uneventful until 29 just weeks, when the mother went into preterm labor. She received one course of pulmonary maturation therapy. Premature rupture of membranes occurred 3 days before delivery, and in spite the tocolysis, the preterm labor could not be stopped, and cesarean section was performed. She fell with the first triplets with a good extrauterine adaptation. She was admitted to neonatal IQ for neonatal respiratory distress and prematurity. And on physical examination, she was eutrophic with a weight of 1,355 grams. She presented with normal glycemia and temperature. She had oxygen saturation about 97%. She had tachypnea and mild chest retraction. Shifa was stable. She was hemodynamically stable. The abdomen was soft and depressible without visceromegalias, and the rest of the physical examination was unremarkable. And to sum up, our patient was a female newborn, the first triplet. She was a preterm 30 gestational weeks with a good Apgar score. She had appropriate weight for gestation age, but she was a very low birth weight infant, and she was admitted to our unit for moderate respiratory distress. This is the first chest and abdominal X-ray of our patient showing good pulmonary expansion and bilateral reticular pattern with acceptable distribution of gas in the abdomen under CPAP. And the initial management consists to CPAP support with minimum oxygen needs. She didn't need surfactant administration. An umbilical catheter was placed and parenteral nutrition was started. She received antibiotics for suspected early onset neonatal infection, and she received caffeine, blood culture, and blood gas analysis were performed. On the second day of life, she passed meconium spontaneously, and the trophic feeding was started on the second day with breast milk and slowly progressed. A PICC line was placed, and on the third day of life, she presented with apnea. And the question, according to you, what are the probable causes of apnea in this newborn? A, hypoglycemia, B, hypocalcemia, C, intraventricular hemorrhage, D, patent ductus arteriosus, or infection. And you can answer. And the answers. And all the proposals were right. In the case of apnea, in the preterm infant, tests we should perform tests. And in our case, biologic tests were negative. CBC, electrolytes, calcium, glycemia, renal function, and CRP was negative, and we stopped antibiotics. Caffeine dosage was normal, and the chest X-ray was performed in order to look for pneumothorax, because the baby was under CPAP, was normal, and both cardiac and cranial ultrasound were without abnormalities. She presented with repetitive and severe apnea, requiring intubation and ventilator support with minima ventilation, and this ventilation lasted 2 days. On day 5 of life, she was extubated to CPAP, and on the 9th day of life, she started on Optiflow. During the hospitalization, she presented with the jaundice requiring phototherapy. She remained respiratory and hemodynamically stable. The abdomen was soft, depressible, peristaltic, without visceromegalias. And on the 11th day of life, she was on continuous feeding with breast milk and preterm formula, reaching 100 milliliters per kilogram per day. On the 12th day of life, she presented with gastrointestinal signs with increased gastric residuals, bilious vomiting, and temperature instability. And as you can see in this photo, the abdominal distension with bilious vomiting. She had tachycardia with good mean blood pressure. She had hypotonia, pylor, and without bloody stools on the examination. According to you, what would be your management in this case? Zero diets, fluid resuscitation, laboratory tests and radiography, antibiotic therapy, surgical intervention, or contrast enema? And you can answer. Okay. I have a problem. Oh, good. And the good answers were A, B, C, D. And in case of suspecting necrotizing enterocolitis and parenteral, we should parenteral nutrition was started, gastric tube for decompression abdomen, fluid resuscitation, analgesic treatment, and the patient received antibiotic with imipenem, amikacin, and vancomycin, and this prescription of antibiotic depends on the ecology of our unit. And complementary investigation were performed. Which tests would you prescribe? Blood culture, arterial blood gas, CRP, CBC, abdominal CT scan, electrolytes tests, abdominal radiography, or stool culture? And you can answer. And the right answers are A, C, D, and E. And in suspecting necrotizes enterocolites, we should practice, or we should perform biological tests and like blood culture, arterial blood gas, CRP and CBC, electrolysis tests, and to confirm and for the diagnosis of NEC, we have to perform abdominal radiography and stool culture. This is the abdominal chest X-ray of our patient. And according to you, what does abdominal X-ray show? You can answer. Okay, and the good answers are C, D, and E. And the abdominal X-ray of our patients show dilated bowel loops with the bowel thickening and pneumatosis. There is no portal venous gas and no pneumonia. Laboratory tests showed metabolic acidosis, high level lactate, leukopenia and anemia in the CBC, and high level of CRP to 245 milligram per liter. And in this situation of the context of the premature with the neck, we have to perform cranial ultrasound to look for hemorrhage, intraventricular hemorrhage. And in our case, the cranial ultrasound was normal. Blood, cerebral spinal fluid, and urine culture were negative. Our patient had tachycardia, and intubation was indicated because of the abdomen distension and oxygen saturation of 80%. She was on parenteral nutrition. She had morphine treatment, but no blood pressure support until this day. On 15th day of life, corresponding to the 3rd day of NEC, she presented with increased abdominal circumference, erythema in the abdominal wall, bradycardia, hemodynamic instability, and increased oxygen need. In this situation, what should we suspect? An outcome of NEC, we should suspect complication of NEC, and the major complication is the intestinal perforation. And suspecting intestinal perforation, we have to perform radiographics. And as we see in the previous conference, we have to perform plain X-ray, abdominal X-ray, and lateral incidence. This is the plain abdominal X-ray of our patient, showing gas under diaphragm. And on this X-ray, it may be not evident The pneumoperitoneum may be not evident, and so we have to complete with the lateral incidence if we suspect perforation, intestinal perforation, and the lateral incidence of our patient showed the gas under the anterior abdominal wall and corresponding to the peritoneum lesion. Perforation, intestinal perforation was major on the first indication for emergency surgery, and before the transfer of the newborn to surgery, we have to practice laboratory tests, and in our cases there are no contraindication of for the emergency surgery. The baby had mild anemia with thrombocytopenia, and the coagulation profile was correct, and CRP was still positive. The baby was transferred to the pediatric surgery department, and a laparotomy, exploratory laparotomy was indicated, confirming the neck involving colon, peritonitis, multiple perforation, moderate ascites, and pyogenic membranes. And the surgical procedure consisted to 20 centimeter intestinal resection, accompanied with end-to-end anastomosis with peritoneal drainage, and a surgical central venous line was inserted. In this slide, you have the photo of the laparotomy, and as you can see, the bowel necrosis, pyogenic membranes, peritinous signs, and multiple perforation. After return from the operating room, the baby had pylor, ventilator support, and gastric decompression. Laboratory test is performed showing anemia, severe anemia at 5 grams per deciliter with thrombocytopenia of 40,000 platelets. The other parameters were acceptable, and the coagulation profile was correct. She had received red blood cell concentration and platelet transfusion. This is the abdominal and chest abdominal X-ray after surgery with the peritoneal drainage. And question, in our case, what were the risk factors of neck? Apnea, antenatal corticosteroids, sepsis, umbilical lines, early onset of enteral feeding, or prematurity? And you can answer. Good. And the good answers and the correct answers are A, C, D, and F. Our patient presented with apnea. She had sepsis, umbilical lines, and she was preterm with very low birth weight. And according to you, in our case, the staging of neck using modified Bell criteria was A, stage 1B, B, stage 2B, C, stage 3A, or D, stage 3B. And you can answer. Okay. And the right answer was, well, is D. Shifa, we can classify Shifa as being in the stage 3B of bile criteria since she presented with systemic signs or systemic manifestation. She had bradycardia, hypotension, instability, temperature instability. She had gastrointestinal signs. She had metabolic acidosis and thrombocytopenia and intestinal perforation. So she presented with severe necrotizing enterocolitis. On the second day of life, she had pallor, an increased bilious gastric residuals, and a fresh sheet bleeding observed by means of the peritoneal drainage. And the photo showing the bleeding throughout the peritoneal drainage. An assessment of the patient was requested to the pediatric surgery department, and a surgical emergency was ruled out. Surgery emergency such as the dehiscence of the anastomosis, the injury during the laparotomy, or liver hemorrhage, and the probable cause of this bleeding may be medical causes, and coagulation profile revealed just thrombocytopenia with a level of 40,000 platelets and anemia at 10 grams per deciliter with coagulation profile, correct coagulation profile. And our patient was transfused with red blood cell and platelet concentration with a good outcome. And in the context with bleeding, anemia, premature infant, an abdominal ultrasound and cranial ultrasound were performed to look for deep hematoma, and abdominal ultrasound revealed a hepatic collection 3 centimeters in diameter. It may be related to abscess or hematoma. Our CRP was still positive 115 milligram per liter. Blood stool culture were negative, but urine culture was positive to Candida albicans. And in this context, our patient was an infant at risk of Candida infection. She was put on injection of fluconazole. In our case, risk factor of candidiasis infection were preterm, very low birth weight, broad spectrum antibiotic, central venous line, bowel rest with parenteral nutrition, neck, intestinal perforation, and digestive surgery. On the 8th postoperative day, she was extubated to Optiflow, and on 9th day of life, she was opening room air with good oxygen saturation. She passed the stool on the 7th postoperative day, and there are no secretion through the peritoneal drainage. Drainage was took off on the 13th postoperative day. There are no orogastric tube output and no sign of local infection. And after surgery notice, the enteral feeding was reintroduced on the 14th postoperative day with formula with protein hydrolysate. And for diagnosis of the hepatic lesion, hematoma or abscess, an abdominal CT scan was performed and showed hepatic subcapsular fluid lesion of 40 millimeter in diameter. And after multidisciplinary consultation with pediatric surgery and radiologist, they concluded to perihepatic hematoma in the process of liquefaction and no suggestion of an invasive investigation. Our patient received 21 days of fluconazole for Candida urinary tract infection, and the CRP was negative on the 22-day post-operative day. The full enteral feeding was established on the 48th day of life, and the bottle was initiated on the 49th day of life with correct gestational age of 37 weeks of gestation. The follow-up of the preterm infant, we performed thyroid tests, and they were normal. An examination didn't show a sign of retinopathy of premature, and a follow-up abdominal ultrasound showed an increase and decreased signs. This decrease had decreased that the lesion decreased in size and then disappeared. And the question, what may be the long-term consequence of NEC in this premature, according to you? Cholestasis, development delay, short bowel syndrome, intestinal structure, or postnatal growth restriction? And you can answer. Okay. And the right answer is A, B, D, and E. Our patient may be not at risk of short bowel syndrome because the resection of 20 centimeters of the bowel was performed. I have a problem to pass. Okay. Our patient was discharged on the 69 days of life with the correct gestational age of 39 weeks gestation and weighing 2,300 grams. This is her growth curve. And on the follow-up, outpatient follow-up, after a period of 6 months, she had weight of 5 kilograms, and complementary feeding was introduced without a problem, well tolerated. An electroencephalography and evoked studies were performed and are normal. And thank you for your attention.
Thank you very much, Dr. Manel Billallah, for this interesting case that illustrates the challenging management of great premature baby in the NICU with many complications and with necrotizing enterocolites with a good outcome. So we have many questions and many comments, and it shows the interest of this subject for the neonatologist, for the pediatric surgeons. So we must choose some questions. So we will start with Professor Mustafa. You have many questions, Professor Mustafa. I try to. From Dr. Fatma Zohra Chouf, she's professor of neonatology in Tunisia. She asks about amoxicillin and clavulanic acid given to mother before birth is related to high risk of NEC. What do you think about this? And what about this attitude in Egypt?
Yes, this is a very good question. As we know, we talk about the microbiota and dysbiosis.
The question from Dr. Karim.
No. Dr. Adil will answer? Or? Okay.
The first one, what was the first?
Okay, Dr. Adil.
The first question, what was
the first question?
Yes, please.
What is the role of infant formula with specific growth factors in premature infant to prevent NEC?
Actually, if we cannot, the priority is the fresh, warm breast milk. If not, we go for the frozen or cool breast milk. If not, we go for donor's human milk. And lastly, the formula. Whatever the formula is, it carries the hazard of necrotizing enterocolitis. This should be the rule. We should know that the golden prevention of necrotizing enterocolitis is to give breast milk as early as possible. The first thing to go into the baby's mouth, it doesn't have to go down into the gut, in the breast milk. Few drops, for swabbing of the mouth of the baby with the breast milk every 3 hours. Breast milk contains probiotics and prebiotics, both of them, pro and prebiotics. So you are building the immunity from the first moment you introduce breast milk into the baby's mouth. I don't say the gut. You're preventing an EC with breast milk. So please try to avoid formula as much as you can. Any comments?
Yes, if up to my knowledge, I don't know if there is a studies comparing the probiotics, or if you mean human milk oligosaccharides, which is newly added within the previous 2 years to the milk. Up to my knowledge, I don't know there is comparison between this formula or standard formula for the outcome of NEC. I don't know if Dr. Adil, Dr. Amin, Dr. Sonia know something about this. I agree with Dr. Adil. Artificial is artificial.
Breast is the best.
Yes.
Dr. Manet, do you have any remark about feeding? What's your practice in you are in the NICU?
Your mic, Dr. Manet.
Micro.
Your mic. Switch
the mic.
In our neonatal IQ,
we start with.
We prefer start with the breast milk, but sometimes we have a difficulty.
Yes.
In developing countries, it's not the same pasteurization and the same. We have not confiance on the breast milk which we receive from the mothers who take the breast milk at home, and after we received the breast milk in the hospital, and we have no idea about the condition of the conservation of the milk, and so we prefer sure the breast milk, but we have not. It's not easy to manipulate in our units, and we use preterm formula, often preterm formula. And the breast, like Professor Amin says is the best, and to prevent neck is the best to prevent the evolution, the outcome of neck in premature infant. And enteral feeding, we must initiate it or started with breast milk formula.
So I have another question that I saw it 2 or three times from Professor Blibish. She's a professor of neonatology at military hospital in Tunis, and also a member of the association. So she asked about the interest of an ultrasound on a sensitive abdomen. It may bother the premature baby and be painful for him. A radiography will be sufficient. What is the interest of an ultrasound? Is it for the diagnosis, for the prognosis?
Actually,
Dr. Adel Riyad or Dr. Mustafa? Okay, Professor Adel.
Actually, he is right. The probe of the ultrasound, it may be painful for the baby. And for this, in such cases, you can use something like the oral screws just to calm him down, or even you can give him an analgesic, but the ultrasound is much more informative than the ultrasound nowadays. Although it's not, I mean, it's not becoming that much common in every neonatal intensive care, but honestly, it is very informative and it's much more better than the X-ray. It is dynamic. It can diagnose the thickening. It can diagnose the tissue damage in the intestine better than the X-ray.
Okay, thank you. So if you have seen some questions in the chat area, or if you want to ask some questions,
I have
to answer
about the biomarkers of neck. This is a very good question and one of the future research area. So the biomarkers, this is involved in the pathogenesis, actually, most of them non-specific. So like to imagine like C-reactive proteins, like procalcitonin, this is help us to differentiate between the sepsis and the sepsis-like pictures without infection. So we have some GIT-specific biomarkers. This is a very good issue for early diagnosis of neck, suspected neck, and for the follow-up of improvement with treatment. And also will help us to when to start the feeding. In some cases, many studies. The most specific is the intestinal fatty acid binding protein and the trefoil factor 3. This is TFF3. And the famous protein is Claudin 3 protein. This is come from the intestinal mucosa itself. However, there is something non-specific. This is released in Claudin protein can be measured in the stool. The others can be measured in the urine and the serum. Other non-specific or less specific, the interleukin 8, amyloid A, something like this. This is area of research. Can we expect or diagnose early neck, follow-up of neck, surveillance of neck, and the sign of improvement? It's a very good question. Another question I read several times about the UVC, UEC, and the neck. Actually, the UEC is sometimes accused for decreasement of splanchnic circulation or intestinal circulation. It is written the UEC in stress suspected neck. We should remove the UVC, UEC if possible. UEC usually, if inserted, I don't know what is regularly inserted in Tunisia or not, But if inserted, we try to remove within 5 to 7 days. So it is mostly not overlapped with the presentation of the necrotizing enterocolitis. UVC, there is no studies about the UVC. One is still connected?
Yes.
Yes.
Yes. Now, yes.
The wrong position of the UVC can increase the risk of necrotizing enterocolitis. This was the retrospective study.
Okay, thank you. Someone asks Professor Mustafa to write these novel bowel biomarkers in the chat area, if possible.
Okay, I can give you a link.
Yes.
I don't know if I can share paper. There is famous paper.
You can write in the chat area.
Yes, okay. I will write the name of the paper. It is very famous. You know the clinics of the seminars or the clinics of North America. This is.
Or you can send us the link to the association or to Professor Emin, and we will share it with you.
Share and you spread it to the audience. Yes.
This is a very good question. This is a very good question. Actually, should be. This is the future. Also, the future is the prevention. They are talking about pathogenesis, talking about toll receptor like 4 antagonists like glutamine and L-arginine plus the lactoferrin. I don't know how to share in the chat. This is the chat.
You can send us and
okay.
When okay.
Okay.
Yeah. So we move to the surgery, Dr. Akhsia, if you want.
Yes.
I have question for Dr. I have question for Dr. Amin before the question.
Yes. Yes.
Is there any rule for laparoscope for diagnosis or management of necrotizing enterocolitis?
Thank you for this nice question. As you know, in laparoscopy, we use the carbon dioxide, and this use it to inflate the abdomen. So you can make the patient worse. And you know, the first rule in medical treatment is primary non-necessary. You should not harm your patient. So I think that this patient that are candidates to laparoscopy should well be chosen. Not this patient that are unstable can perform laparoscopy. So I prefer to not choose laparoscopy, really.
Sure, this was my mind during your presentation. Thank you very much.
You are welcome.
You are compressing, you are compromising the intestine with the blood flow to the gut. So it's better to be avoided. Yes. Yes. Actually, what we do is we let the pediatric surgeon participate with us in the decision as soon as we suspect necrotizing enterocolitis. From early beginning of suspicion, we call for help from the pediatric surgeon to keep an eye with us on the baby. Yes. Not to miss early intervention. Early intervention is extremely important. So it's a teamwork. It's a teamwork. I cannot say, please come to do the surgery. No, this is not my job. If I suspect, this is your intervention, not my intervention. So we have to be working in a teamwork, pediatricians or neonatologists together with the pediatric surgeon.
The scenario usually don't go like this all the time, Dr. Adel. Sorry to try me.
So we have to be in good terms with the pediatric surgeon.
Yes.
There is what should be done. There is what should, excuse me. There is what. Yes.
Dr. Emil, you listen. So from Professor Fatma Zohra Shouf, again, to Dr. Emin in the same idea. Do you think that the surgeon must examine the baby with the neonatologist in order to choose the best solution if surgery is indicated? And she said, it's a beautiful presentation.
Thank you. Thank you for my dear friend, Dr. Fatma Shoukh. So it's the same idea that was raised by Dr. Adel Riyadh. I think there's what should be done and what could be done. What should be done is that the pediatric surgeon should be incriminated in the management of neck from the beginning. This is what we were used to do in El Hada with Dr. Mustafa. Each patient with neck should always be informed. The pediatric surgeon should be informed about the patient, because the main point is to choose the appropriate time to operate. We don't like to operate this patient very late and to lose this patient. So it's very important to look to this patient. And for me, you should see this patient every day, not wait till we have complication or wait till the indication of surgery is clear. But I know what Dr. Fatma is wanting to tell. In some cases, the pediatric surgeon is not available or is far from you. So here the neonatologist will give the indication to surgery. But here we should discuss phone. The pediatric surgeon sometimes should move to the patient to see him, or you can have videos, we can have exchange of x-rays. It's not official, it's not really legal to make decision on photos, but perhaps this can give us solution to manage this patient. I don't know if Dr. Adel have any comments of this.
Actually, sorry, yes. I do agree. We have, if we don't have, which is extremely unlikely if you are working in a neonatal intensive care in a hospital, there should be a pediatric surgeon. But if you are in a remote area, you can share the history, you can share the lab, you can share the x-rays, you can share the progress of the baby with the pediatric surgeon, together with the phone call, together with the video call. I mean, it's the communication. Our late professor, Professor Ahmed Sami Khalifa, is one of the pioneers in hematology and oncology in Egypt. He used to say lack of communication. This is the problem, lack of communication. This is true. We have lack of communication. That's why we have to communicate with the pediatric surgeon in a way or another. We don't take the decision from our side only. If I suspect a patient with, for example, appendicitis, I should say go for the pediatric surgeon, because he is going to decide whether to do the operation or not. Because I'm not the one who is going to do the operation. He is the one to go. He will do the operation. So the final decision is of the surgeon, not the pediatrician. The same with the neonatologist. We have to have a common language. We have to have communication. This is very important. So whatever the distance, we have to transfer, to convey the data, all the data to the pediatric surgeon to help him to have an idea about the case, and then he can give us his opinion until he comes to the hospital to see the patient live.
Professor Adel or Professor Mustafa, in the same idea, do you think that a department of neonatal surgery, not pediatric surgery, surgery only for neonates, could improve the outcome of the neck or other pathologies of the neonates, surgical pathologies?
Definitely.
I think you have that in Egypt.
Definitely.
I think you have such a department.
No, up till now we have pediatric surgeons who are becoming specialized in neonatal surgery. Okay. There's not up till now a department of neonatal surgery.
Excuse me, Dr. Adel. Yes, the same person, neonatal pediatric surgeon, the same person, but you know, Banha Children's Hospital, this is not belong to the university hospital. We have neonatal surgery unit, isolated neonatal surgery unit with his. Okay. It's an isolated team. The consultant is different. It's covered by the resident of the surgeon and surgery, and resident of pediatric surgery. Neonatal resident also. I think this is the only place. I don't know if have a unit like this or not. So my unit, I cover one unit, the big units have 32 beds. We are not admitting surgery patient at all. Should be admitted there. I think this is reflected on the team. We have more experience than us in the management, especially for short bowel, TBN management, stoma care, replacement therapy. This is different. But we have no studies about this, actually.
Professor Emin Sia, you have a question from Professor Mohsen Belghi. He says, thank you, Professor Sia. How to improve result of surgery? Is it by drainage, laparoscopy, or stomy?
Thank you for this nice question from my master, Professor Belghi. I think that the improvement of the results is not the matter of the surgical technique, but more it's the matter of the appropriate time of surgery, first of all, and also the prevention. Prevention of neck and prevention of severe forms of necks. And the knowledge of the risk factors, the discussion, the honest discussion between the neonatologist and the pediatric surgeon. And you know, such webinars can enhance the communication between pediatric surgeon and neonatologist to reach this goal, to enhance or to promote the neck management, are very mandatory in the improvement of neck management. So to summarize, the appropriate time, the knowledge of the risk factors, the communications, more than the technical surgical technique or the procedure that you will choose.
Okay, do you need another question? So last question for Dr. Emin Qsia for surgery. It's from Dr. Farid. From Dr. Yes. Farid, he asks about the number of drains to put, just one or more?
It's here also, it's a very nice question from Professor Farid Alleghi from Libya. Personally, I prefer to put 2 drains. Why 2 drains? Because sometimes you have adhesions in a part and you cannot drain all the peritoneal cavity. So I prefer to put at least 2 drains to be more sure to drain all the cavity. Especially, you do this drainage blindly. So I prefer to put 2 drains.
Okay. So Professor Mustafa, do you have a comment?
Yes, I read the pictures, which is important in practice. The question was the place of occult blood screening for the neck. It is a part of lab work. Actually, the false positive results of occult blood in stool is very high, and sometimes is misleading for us. We have many cases with anal fissures give positive blood and no neck. This is true, there is some association. One study show association between the anal fissure and the neck after that. But this is important question because I met some of our colleagues which is just do occult blood in stool and stop feeding because it's positive. And when we review the other clinical pictures, nothing, just the distension, just small residual. So it's not a part, it's very misleading. We have a major sign and symptoms of diagnosis of neck other than occult blood in stool. Thank you to give me time. Dr. Adel,
yes. One of the most important things to stop enteral feeding This is a very senior decision. This is a very senior decision. This is not the decision of the most junior in the unit. To stop nurse, to stop enteral feeding, this is a very serious decision and should be taken by the most senior personnel, because leaving the gut empty will increase the risk of sepsis, which is followed by increase of the risk of necrotizing enterocolitis. So please, this decision should be taken by the most senior personnel. This is number one. Number two is the I forgot, but
Cult of blood, maybe.
This is very,
so I don't know what is the situation in Tunis, because usually we start feeding at morning, and the residents stop feeding at night.
Oh no, this is not allowed at all. The Joseph Nu, Professor Joseph Nu, I met him several times, and he's fascinating. For me, I love him a lot. When we were talking about residual, he said, "What do you mean by residual?" You see, he wants to say that please do not check the residual. It will mislead you. I stopped years ago, even before I meet Professor Joseph Nu, the checking the residual and putting the nasogastric tube and GT and the aspiration of the gastric content. You're doing a biopsy. You're bleeding, and then you see the occult blood in the stool, and you see the hematemesis. Please, the maximum you can do is to leave the NGT open half an hour before the next feed. Please do not aspirate the stomach. You are hurting the baby. You are doing harm. Even with the smallest syringe, they say you use the insulin syringe to minimize the suction force. Please avoid suctioning. Avoid using the aspirate to diagnose or to evaluate the residual. The concern is the bilious vomiting. This is the concern. Although bilious vomiting, not in the aspirate, because there is the antiperistaltic waves, antiperistaltic movement, which may bring some of the bile into the stomach. It will be greenish, but it doesn't mean this is bile stained. This is a sign of intestinal obstruction or so. So please, bilious vomiting, it's okay. This is serious. But the color itself alone, the antiperistaltic waves, it brings the bile into the stomach. So please be careful with the aspirate. It's misleading. That's it.
Thank you very much. So we've been here for more than 2 hours and a half. I want really to thank both of you, to thank my friend Dr. Amin, Dr. Manel for its case. We still have with us more than 130 participants. There are other questions. We can't answer all the questions. So we are looking forward to collaborating with you other times. Do you want to have الكلمة الأخيرة in Arabic?
Final comments.
I would like to say
you can talk in Arabic. Professor Mustafa and Professor Adel, we can talk in Arabic after the permission of the participants.
Okay. First, thank you very much. It was great pleasure and honor being with you. I really enjoyed it. I really enjoyed it. And thank you very much for the invitation. It's a great honor, honestly. And I really enjoyed it. شكرا جزيلا، شكرا جزيلا على الدعوة الكريمة. شرف لي وجودي معاكم. I really enjoyed it. أنا فعلا استمتعت بوجودي معاكم واستفدت من وجودي معاكم، وبشكركم على دعوتكم، وبشكر ابني الغالي دكتور مصطفى على المحاضرة الطيبة.
ما تحبش بحضرتك دكتور عادل، ربنا يخليك. أنا بشكر حضرتك وجود حضرتك معانا، وبشكر الدكتور أمين والدكتورة سونيا للدعوة. فعلا شرف كبير لي أن أنا أكون مع حضرتك، وسعيد جدا جدا جدا. دكتور أمين يعرف معزته الشخصية عني، أنا أحبه في الله. ربنا يبارك في حضراتكم، وبشكر الأودينس اللي صبرهم علينا ومشاركتهم فعلا الفعالة. very 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 high quality of questions and interaction. ونشوف دايما حضراتكم على خير، ويشرفنا دايما نكون معاكم.
شكرا شكرا دكتور أمين. دكتور أمين.
I would like to thank you, Professor Sonia Nouri, for the nice moderation, and of course, Professor Adel Riyad. Really, I discovered a very nice person, very high qualities, scientific qualities, and very high human qualities. Dr. Mustafa Habibi, yani, he's a very dear friend. I discovered him when I worked in Al Hada. He's really a very nice person. You know, he's your best friend. From the first sight, he's your first friend. And of course, my friends from the NICU, all the neonates, I love really the neonatologists. I think that they are the best doctor. They are always working, caring about the patient. I think فما بركة كثيرة يعني في العمل متاعهم. And God bless you. I hope that such webinars will enhance the collaboration between pediatric surgeon and neonatologists for the interest of this babies, because this is our last goals, is to save this patient. And I hope also that the politicians will understand this. You know, a baby that is saved would be a very active person in the future, and they are spending a lot of money, excuse me if I'm telling this, they are spending a lot of money, for some specialties to add 5 years or 10 years in the life of a person, and they are not thinking about this neonates. I think that this policy must change a little bit. Wish you all the best for the future, and I wish really to meet you physically in the future. And for this discussion, hope that this discussion will continue in the future by emails and in others webinars and in other physical meetings. Hope so. Thank you very much.
إن شاء الله إن شاء الله.
شكرا جزيلا، شكرا جزيلا.
شكرا، تصبحوا على خير. شكرا، شرفتونا. عيش.
بإذن الله. السلامة دكتورة سونيا، دكتورة منال.
مع السلامة. عيشك.
Happy New Year.
كل سنة وحضراتكم طيبين.
كل سنة وانتم طيبين جميعا. كل سنة وانتم طيبين.
كل سنة وانتم طيبين. stay safe. وإن شاء الله في مواعيد قادمة.
إن شاء الله. نراكم على خير دائما بإذن الله. السلام عليكم.
مع السلامة.
سلام.